Welcome to the Australian Dental Council Explainer podcast. Before we begin, please note that this content is purely educational and not a commercial endorsement. Today, we are really bridging two massive clinical disciplines for you.
Right, because if you're an overseas trained dentist or an ADC candidate, you need to be able to shift your mindset instantly.
Yeah, exactly. 1 minute, you're basically a structural engineer, manipulating millimeters of wire to guide facial growth, and the next minute, you're a cellular detective looking for microscopic signs of premalignancy.
It's a profound transition, and mastering that pivot is crucial, not just for the exam, but for daily clinical practice.
For sure. So welcome to the deep dive. Let's start with the engineering side of things, specifically case 51. Imagine an 8-year-old girl sitting in your chair. Her mother is terrified.
Because of how the lower incisor looks, I imagine.
Oh, exactly. It looks like her daughter is just rapidly losing a permanent lower incisor to severe bone loss. I mean, the gum line is completely stripped away on the lower left central.
But when you look closer and evaluate the eruptive stage, you realize it's not actually bone loss at all.
Right, it's more of an optical illusion of the developing mouth. But extraordinarily, just to set the baseline, everything is entirely within normal limits for this patient.
Okay, so no facial asymmetry.
Nope. And importantly, no clicking, crepitus, or locking in the TMJs.
Noting that negative finding for the TMJ is, well, it's a baseline requirement for the ADC exam. You have to establish there's no pre-existing joint pathology before assessing the occlusion.
Because the occlusion we're about to evaluate has a massive direct impact on joint health down the line. So, intrally, we find crowding in the upper and lower incisors.
Let me guess. Anterior crossbite.
You guessed it. The upper left central and lateral incisors are in crossbite. But that standout finding is still the lower left central incisor. It's labially placed, and there's that significant loss of attached gingiva.
Right down to the mucogingival junction, usually.
Yeah, exactly. Now, I want to unpack this visual. When a candidate sees a dramatic loss of attached gingiva in an 8-year-old, the immediate instinct is to sound the alarm.
Sure, because it looks like adult periodontal disease.
Right. It looks like a receding tide that has suddenly dropped, exposing the rocky foundation below, like it's signaling irreversible periodontal destruction. Is this tooth already severely compromised?
It's completely logical to view it that way if you're applying an adult perio framework, but the clinical reality of an 8-year-old is driven by eruption dynamics.
So it's not necessarily disease at this stage.
Exactly. At this age, that permanent incisor is still actively rising through the alveolar bone. The clinical crown isn't even fully exposed yet.
So when the tissue pulls back, what we're actually seeing exposed is enamel, not cementum.
Spot on. It's premature gingival regression rather than true recession. True recession implies the apical migration of the junctional epithelium along the root surface, past the CEJ.
Got it. So the tide hasn't pulled back to expose the root. The tooth itself is just, well, still rising out of the water.
That's a great way to look at it. The tissue is simply stretched thin over a labially displaced, partially erupted crown. Now, it absolutely requires monitoring to ensure a band of keratinized attached gingiva remains.
Right, as the child grows. But there's no permanent structural damage to the periodontium yet.
Right. And that distinction changes the entire risk profile of the case.
It really does.
Yeah.
But to keep that tooth safe, we have to address why it's displaced in the first place. And the exam requires specific functional checks here. You can't just diagnose a crossbite visually.
No, you have to evaluate it kinetically. You need to guide the patient into a hinge axis closure and observe the exact initial point of contact.
Okay, so in this scenario, the patient can achieve an edge-to-edge incisor relationship. But that initial premature contact occurs right on that labially displaced lower left central incisor.
And they can't stay in that edge-to-edge position, right?
Exactly. The mandible has to slide to find maximum intercuspation.
That sequence right there is critical. That initial contact forces a forward displacement of the mandible. Identifying this functional shift is basically the linchpin of the diagnosis.
Because if you just leave that displacement untreated, you're allowing microtrauma to occur thousands of times a day, every single time the child swallows or chews.
You're subjecting that lower incisor to continuous non-axial occlusal loading. And over time, that will turn our benign gingival regression into true, irreversible periodontal destruction.
Wow, so the bone loss would become very real.
Oh, absolutely. Furthermore, chronic forward posturing of the mandible alters the muscular dynamics and condyle position. That sets the stage for severe TMJ dysfunction in adulthood.
Okay, so we have our diagnosis and the biomechanical mechanism. Let's move to intervention. Translating these findings into a treatment plan requires targeted investigations.
We definitely need a dental panoramic radiograph for a comprehensive survey.
Right. And we also need periapical views of the upper incisors, to assess root development and rule out supernumeraries or root fractures.
You might also consider a periapical of that lower left central incisor using a paralleling technique. That helps assess interproximal bone levels.
But there is a physics limitation to 2D radiography here that candidates really need to acknowledge. The paralleling technique is great for mesial and distal bone crests.
But X-rays compress a 3D object into a 2D shadow.
Exactly. So the dense structure of the tooth root superimposes entirely over the thin labial cortical plate.
Which is a critical limitation to articulate in an exam setting. You will not be able to visualize labial bone loss or fenestrations on a standard PA film. You have to rely on tactile and visual clinical assessment.
So bringing all this data together, the definitive diagnosis is ectopic eruption of the upper incisors in association with crowding. To resolve the crossbite, we first resolve the crowding.
Orthodontic movement requires a path of least resistance. You simply cannot push a tooth into a space that doesn't exist.
Right, physics won't allow it. So the protocol dictates extracting all deciduous canines and the upper left deciduous lateral incisor.
By removing those specific primary teeth, you immediately relieve the crowding pressure. It creates the physical space for the permanent upper incisors to move labially.
And once that space is available, we design the active appliance. An upper removable appliance, or URA, is indicated here. And for the candidate, the metallurgical specs are highly testable.
Oh, they love testing appliance design. What are the specs for this one?
So the design specifies Adams cribs on both upper deciduous first molars, the Ds using 0.6 millimeter stainless steel wire, and then cribs on both upper first permanent molars, the 6s, using 0.7 millimeter wire.
It all comes down to tooth anatomy and the physics of retention. Deciduous molars have a very bulbous clinical crown and much shallower cervical undercuts compared to permanent molars.
The wire needs to be different.
Exactly. A 0.6 millimeter wire has greater flexibility. It can flex over that bulbous contour and engage the shallow undercut without undergoing permanent deformation.
Whereas a permanent first molar is a much larger tooth, right, with deeper undercuts.
Right. If you used a 0.6 millimeter wire there, it would just be too flimsy. You need the increased rigidity of the 0.7 millimeter wire to provide strong retention.
To really anchor the appliance while the active springs push the incisors forward.
Exactly.
Okay, that makes the mechanical necessity very clear. But here is a nuance that constantly trips candidates up. Standard orthodontic teaching for an anterior crossbite frequently utilizes posterior capping, or an anterior bite plane, right?
To jump the bite, yes.
Right. The idea is to prop the blade open, disoccluding the front teeth so the upper incisors don't crash into the lower ones. Why is an anterior bite plane strictly contraindicated in this specific design?
This requires looking at the vertical dimension of the patient's whole occlusion. In this specific case, we have a reduced overbite.
Meaning the upper teeth overlap and lower teeth vertically by a very small margin.
Right. Because the overbite is already minimal, there's hardly any occlusal interference preventing the forward movement of the upper incisors in the first place.
So the clearance we usually need to create is already naturally present.
Exactly, but the strict contraindication is driven by what happens to the posterior teeth. If you insert an anterior bite plane, the front teeth occlude on the acrylic.
And the posterior molars are held entirely out of occlusion.
And nature abhors a vacuum. If teeth have no opposing contact, they will over-erupt.
Wow. Okay. And if those posterior molars over-erupt even by just a millimeter, it props the entire mandible open permanently.
Which would completely obliterate the patient's already reduced overbite. You might fix the crossbite, sure, but you'd iatrogenically create an anterior open bite.
Which is a far more complex malocclusion to fix.
Much more complex. It's a brilliant example of treating the holistic system. If you manage the space correctly without disrupting the vertical dimension, the outcome is highly predictable.
Within 3 to 4 months, the crossbite is eliminated. And once that traumatic premature contact is gone, the mandibular displacement resolves instantly.
And without that constant microtrauma pounding against the lower incisor, the gingival inflammation subsides. The tissue regains its normal contour as the alveolar bone matures.
Such a satisfying clinical result. Okay, so we've managed the biomechanical forces. Now we are going to drastically shift our clinical focus.
Ready for the pivot.
We are moving from the macroscopic space management of pediatrics to the microscopic soft tissue diagnostics of oral pathology.
The underlying clinical philosophy remains the exact same, though. Early intervention prevents catastrophic failure.
Just as we intercept a crossbite to prevent structural damage, we intercept soft tissue lesions to prevent cellular damage that can become life-threatening.
Let's apply this to case 45. A 52-year-old woman presenting with a mixed white and red nodular patch on the lateral border of her tongue.
This presentation immediately forces the general practitioner into a critical decision-making process regarding biopsies. And a lot of candidates hesitate here.
They do. They really struggle to define the boundary between what they should actively investigate in general practice and what mandates an immediate, untouched referral to an OMFS.
I think we could view the GP's role here as acting like a clinical triage. You are the first line of defense.
You manage the initial investigative biopsies to establish a baseline, but you immediately refer out anything that screams high risk.
Or anything requiring complex surgical management.
Yeah.
But the rules for clinical triage are quite rigid, right? In general practice, you do not biopsy suspected outright malignancies.
Or highly vascular lesions where hemorrhage control is a major risk. Or lesions in anatomically hazardous areas.
And you also avoid biopsying benign, self-limiting conditions that can be diagnosed clinically or radiographically, like fibrous dysplasia.
Exactly. However, a mixed red and white nodular patch on the lateral border of the tongue, that is a prime candidate for an incisional biopsy in a general setting.
Our primary objective there is to exclude squamous cell carcinoma. And if it's not malignant, our secondary objective is to evaluate the tissue for dysplasia.
Dysplasia is the critical concept here for the exam. It signifies disordered growth. It's the cellular precursor to cancer.
And as an ADC candidate, you are absolutely expected to understand exactly what a pathologist is looking for under the microscope.
You need to know the histological jargon.
Let's demystify that jargon then, because it essentially just describes cellular chaos. The first red flag is drop-shaped REIT ridges.
Normally, the REIT pegs of the epithelium interlock with the underlying connective tissue in a neat, undulating pattern.
Like an egg carton. But in dysplasia, the proliferating epithelial cells at the basement membrane begin to bulge and swell downward.
They completely lose their uniform shape. They look like heavy water droplets about to fall into the connective tissue below.
Then we have basal cell hyperplasia. The basal layer is basically the factory of the epithelium. In a healthy state, it produces cells at a steady rate.
But in dysplasia, that factory goes into overdrive. It creates an abnormally thick layer of basal cells,
which leads directly to irregular stratification. A healthy epithelium has a highly organized progression, right? Plump cells at the bottom slowly flatten out as they migrate to the surface.
Dysplasia destroys that orderly traffic. The layers become completely disorganized and chaotic.
And finally, nuclear pleomorphism. Let's break that word down. Pleo meaning many, and morph meaning shape.
The nucleus holds the cell's DNA. Because the DNA replication in dysplastic cells is erratic, the nuclei become vastly different sizes.
Different sizes, different shapes, and they are intensely dark staining compared to normal cells.
When you see those terms on a pathology report, you are looking at the chemical smoke before the fire of carcinoma ignites.
It dictates a really aggressive monitoring or surgical excision protocol. But beyond the scalpel, modern diagnostics often involve optical adjuncts to help identify these changes early.
Right, before they're even clinically obvious. Let's look at the physics behind autofluorescence.
Healthy oral mucosa contains specific molecules, like collagen and fluorophores, that naturally emit a green fluorescence under blue light, right?
Exactly. And the mechanism here is that dysplastic and malignant tissues undergo severe biochemical changes that disrupt these molecules.
So under the blue light, healthy tissue glows a pale green, while a dysplastic lesion loses that fluorescence. It absorbs the light and appears as a dark, demarcated area.
We also utilize chemiluminescent light examination. This typically involves preparing the mucosa with a mild acetic acid rinse.
The acid acts to temporarily coagulate the elevated levels of intracellular proteins and DNA found in dysplastic cells.
Right. And when illuminated with a specific white light, these abnormal protein-dense areas reflect the light far more intensely. They appear bright white.
Now, these optical tests don't replace a biopsy, obviously, but they drastically increase your visual acuity, helping you choose the most accurate site to actually take your tissue sample.
It guides your scalpel to the most active part of the lesion.
Okay, as we enter the final segment of our deep dive, we need to apply this diagnostic mindset to broader systemic presentations. You have to connect localized oral symptoms to whole-body conditions.
Case 28 is a perfect example of this.
Right. Consider a 20-year-old male who presents to your clinic feeling generally ill. He complains of a severely painful mouth. But the pivotal finding isn't intraoral at all.
It's during the extraoral exam.
Exactly. You palpate enlarged, mobile, and tender cervical lymph nodes.
That finding completely alters your diagnostic pathway. A localized dental issue, like a carious lesion, rarely causes bilateral tender cervical lymphadenopathy alongside systemic malaise.
The lymph nodes are acting as an alarm bell. They indicate the immune system is battling a significant regional or systemic infectious process.
This strongly points toward viral infections like primary herpetic gingivostomatitis or severe opportunistic infections.
Like severe candidal infections, which can present with widespread mucosal pain. And we must remember that systemic factors, like uncontrolled diabetes, create an immunosuppressed environment primed for candidal overgrowth.
When you suspect candidiasis in a complex case like this, your investigative method really matters. A general saliva sample is inadequate.
Because it only measures the overall yeast load in the mouth, which fluctuates based on diet or denture wear.
Instead, you require a smear taken directly from the symptomatic buccal mucosa. A smear physically scrapes the superficial epithelial cells,
Which allows the lab to identify whether the candida is in its harmless yeast spore phase, or if it is transformed into its pathogenic invasive hyphal phase, actively penetrating the tissue.
Moving from infections to surgical sequelae, candidates must confidently manage exodontia risks, particularly oroantral fistulas, or OAF.
The anatomy really dictates the risk here. The roots of the maxillary molars often protrude directly into the floor of the maxillary sinus.
Separated only by a paper-thin layer of bone, or sometimes literally just the sinus membrane itself.
Right, so when you extract that molar, you can easily tear that membrane, creating an oroantral communication.
And if the communication is large, or if the patient creates negative pressure, say, by smoking or using a straw, that temporary hole can epithelialize.
It turns into a chronic, permanent tunnel, a fistula connecting the mouth to the sinus cavity.
Managing this usually requires surgical intervention, utilizing techniques like advancing a buccal fat pad or rotating a palatal flap to achieve primary closure.
Finally, we have to emphasize the massive impact of systemic pharmacology on the oral cavity. A vast array of medications can trigger adverse oral reactions that perfectly mimic autoimmune diseases.
The classic example is a lichenoid drug eruption.
Clinically, it looks identical to oral lichen planus. White, lacy striations, often with painful erosive areas on the buccal mucosa. But the etiology is entirely different.
The mechanism here is a type 4 cell-mediated hypersensitivity reaction. The medication acts as an antigen.
The patient's own T cells mistakenly identify the basal keratinocytes of the oral mucosa as foreign invaders and attack them, causing the blistering.
To manage this, you don't necessarily need potent topical corticosteroids. You need to identify the offending drug.
Right. The classes most frequently implicated include antihypertensives like captopril and beta blockers, gout medications like allopurinol, and common NSAIDs.
It is a stark reminder that a patient's medical history is the master key to solving complex oral medicine presentations. You cannot treat the biology of the mouth without understanding the pharmacology in the bloodstream.
Which reinforces the core philosophy of the ADC exam. You are not just a mechanic of the teeth, you are a physician of the oral cavity.
Well said.
Which brings us to our final synthesis. Think about the massive clinical spectrum we have covered in this deep dive. As a candidate, you are expected to be incredibly adaptable.
In one scenario, you're evaluating the metallurgy of a 0.6 millimeter stainless steel wire to resolve a pediatric crossbite.
Utilizing physical forces to protect the temporomandibular joint.
And in the very next scenario, you are evaluating the histological architecture of a tongue lesion, searching for nuclear pleomorphism to protect the patient from squamous cell carcinoma.
You are seamlessly integrating structural biomechanics with cellular pathology. Before we wrap up, I want to leave you with a final provocative thought. Consider how the age of the patient fundamentally redefines your entire risk assessment protocol.
It really is the ultimate diagnostic filter. If an 8-year-old presents with a displaced tooth and a fiery red patch of gingiva, it's almost certainly a puzzle of eruptive dynamics.
Space management orthodontics. But if a 52-year-old presents with a displaced tooth, a fiery red nodular patch of mucosal tissue, the biological context is inverted.
Suddenly, that presentation might be the very first sign of an aggressive underlying malignancy destroying the alveolar bone.
The visual clinical signs might look vaguely similar on the surface, but the patient's age dictates an entirely different diagnostic urgency. How does age calibrate your baseline index of suspicion? Food for thought. For more dental examination prep tips and clinical deep dives, please subscribe and share this episode.